All right, I've got it working.
Excellent.
Well, thank you so much for having me today. I'm really always happy to talk about what I do in ocular oncology and provide updates, and welcome to any people who have been my patients. Gerald, thank you for pointing yourself out. It's nice to see you again. It has been a while. So today I'm going to share with you some information about ocular melanoma, everything you wanted to know but were afraid to ask. So this is a picture of a very typical ocular melanoma, which is a type of rare cancer in the eye. You can see in the background that there's the healthy retina in red with the blood vessels, and the tumor is sitting on top there, brown, pigmented, and elevated, so slightly out of focus. What we're going to talk about today is what is ocular melanoma? How do we diagnose it? How does it affect patients? How do we treat it? And some details and information about our ocular melanoma program at UCLA. What is ocular melanoma? So we use the word ocular to talk about this type of rare cancer, but it also goes by uveal melanoma or the word choroidal melanoma, terms that basically mean this is a cancer in the back of the eye, or it can involve the iris because all those tissues are related. Ocular melanoma is the most common primary intraocular tumor of adults. So that means the types of cancer that actually start in the eye, this is the most common type. However, it is still rare, with only 5 to 6 cases per million per year. So that's about just over 2,000 cases every year. We don't have any known external risk factors or exposures, such as cell phone use, exposure in certain types of occupation. There's been a lot of studies on that, but we have not found or discovered anything conclusive. We do see more people affected with this who have blue or green eyes, and it is more prevalent in people who have less pigmentation of their skin. So ocular melanoma can also be associated with other types of cancer in a patient's family. It is not usually hereditary, meaning it can be passed through the generations, but there have been a very small number of families that do have a mutation that is heritable, and this is called the BAP1 family predisposition syndrome. And these few families are being studied right now so that we can understand how they're susceptible to ocular melanoma. And in this rare type, there is a mutation in the gene that is passed on to generations. We call it melanoma because it originates from pigmented cells in the uvea, and the uvea refers to the iris, the choroid, and ciliary body. A question that comes up a lot is ocular melanoma related to skin cancer? Well, no is the short answer, but both types of cancer originate from pigmented cells, and both have similar risk factors. I would say that they are more like cousins, because when we look at it from a molecular level, their biology is totally different. Skin melanoma have very specific mutations. There's a BRAF mutation and NRAS mutation that we do not see in ocular melanoma. In ocular melanoma, we see commonly GNAQ and GNA11 mutations that are related to tumor development. They are also different in their pattern of metastasis if the cancer were to spread. In ocular melanoma, the cancer usually spreads, if it were to spread, to the liver primarily. And in skin melanoma, if metastasis occurs, these cancers can be found throughout the whole body. Should skin melanoma patients be screened for ocular melanoma? This comes up very frequently. And because skin melanoma is so much more common, it's not unusual to see it in people who also have ocular melanoma. And should ocular melanoma patients be screened for skin melanoma? Well, we recommend that people see their primary care physician and do their usual surveillance for overall health. And some patients may have both conditions, usually due to the similarity in their risk factors, but they are not actually related. Let's review how this cancer grows and affects the eye. So this is a diagram of a cross-section of an eyeball that has been cut in half. So you can see what the contents are. On the left side, you have the cornea, the front of the eye, the part that you can see in this picture here. The front of the eye is the cornea. It's a clear coat. And there's a little space between the cornea and the lens, which we call the anterior chamber. And that's all up at the front of the eye that you can look at with when you put your chin on that microscope when you see your eye care professional. The lens, that white oval structure, is what develops into a cataract when people get older. It's living tissue. And when people have cataract surgery, that is a structure that gets removed and replaced with an intraocular lens implant. Now, everything behind that lens, so all the red part in the back, is what we call the posterior segment. And that is the back part of the eye. And that is where the retina is. And you can see the retina lines the inner aspect of the eyeball. And it is made of neural tissue that all comes together at the optic nerve, the very back of the eye. And that optic nerve goes to the brain and gives you the images and signals that result in your vision. Now, if you were to develop an ocular melanoma, I've drawn that in here where it says tumor. The melanoma itself comes from pigmented cells that originate in the choroid, the very rich layer of blood vessels that lie behind the retina. The pigmented cells in there, for some reason we don't understand, become abnormal and began to grow into a tumor. So that's where ocular melanoma in the back of the eye can be found. If a person has an iris melanoma, the iris is that structure that forms the color part of the eye. The tumors can be seen there and are usually more visible. Here is a side view of a real eye in a histopathology lab that has been sectioned open. And you can see it's oriented the same way as the previous diagram. The front of the eye, the lens of the eye that's there, and the melanoma is that mushroom-shaped mass at the bottom of the eye. And you can see that it has caused a retinal detachment. That thin, wispy structure is the retina. And normally it lies perfectly flat against the inner aspect of the eyeball. So in cases of retinal detachment, that structure comes off as shown in the picture. So how do you diagnose an ocular melanoma? Usually, ocular melanoma, we have found, is detected on a routine eye exam. And that's why it's really important to get your eyes examined with dilation or with a photograph so that the inside of your eye can be known. Sometimes people have altered visual symptoms. That means they can have blurry vision, or they notice a blind spot, or they develop flashes. And this results in people seeing their eye care professional, and then the diagnosis can be made. There are other people who already know that they have a freckle or a mole in the back of their eye, which is being monitored. Sometimes those freckles and moles can turn into a melanoma, similarly to how an unusual freckle on your skin may be monitored to check if it becomes a skin melanoma. Here are some examples of what an ocular melanoma look like. And these are different types of photographs, but you can see that melanomas of the eye look very different. So to the top left, you have a big bulge in the corner, and that person's melanoma might not really give them any symptoms until it is very late. At the bottom left, there's a sort of irregular brown area that is covering the center of the retina. And that tumor may start to affect vision early. And then we see a melanoma in the top right, and there's some hemorrhages of the retina that are associated with it. And then lastly, we have an iris melanoma. And in general, iris melanomas are detected earlier than the melanomas in the back of the eye because they're at the front and sometimes can be more visible to people who will go and seek attention. Here's an example of a color photograph that was taken that can detect a melanoma. And there you can see the tumor, the brown elevated lesion that is in a normal healthy retina. We use fluorescein angiography, which is a type of test where vegetable dye is injected into the vein and the dye passes through all of the vessels in the body very quickly. And then we can follow this on imaging and see how the blood flow is in certain parts of the retina. And you can see here that there is some collection of the dye in the tumor itself. We also use ultrasonography. Just like ultrasound on other parts of the body, ultrasound of the eye uses a small probe that goes on the surface of the eye and can tell us important information such as the characteristic of sound waves through lesions in the retina, which can help make a diagnosis. Ultrasound can also help us in monitoring treatment effects because we can see and measure tumor response by watching for shrinkage. Other types of imaging that we use are OCT, which stands for optical coherence tomography. And here you can see a cross-section of a tumor, and the tumor is represented by the bulge, and there are the dark spaces above it, which indicate retinal edema or fluid, which can indicate activity of a suspicious lesion. How does ocular melanoma affect patients themselves? Well, there are two main ways that I think are very important on how melanomas of the eye affect people's lives. The first is vision loss. Vision loss or visual disturbance can come from the tumor itself that is disrupting the eye. And you can see in the pictures that I showed, melanomas can form in all sorts of different parts of the eye, and some may affect the vision and some may not. So if the tumor is in a more sensitive part of the eye, then this can have more of an impact on people. Vision loss can also occur from side effects of the treatment. We will talk about some of the common treatments, including using radiation therapy. And although this is very successful at killing cancers, it can also cause some harm to the healthy tissue in the eye. The second most important, and probably more important than vision loss by itself, is the risk of the cancer spreading or metastasis, which can result in death. In ocular melanoma, if the cancer ever were to spread, it tends to go to the liver. And the liver is the organ that we have to monitor very closely. Pointed out that it is rare to have metastasis at the time the ocular tumor is discovered. And that is something that it's important to point out, that when we find the tumor in the eye, the person almost always has a healthy examination of the rest of their body. And then we can work towards maintaining good health in the future. Let's talk a little bit more about ocular melanoma metastasis when the cancer, if the cancer should spread. What are the risks? What people may be more at risk of getting spread of their ocular melanoma? Probably the most important risk factor is tumor size. The larger the tumor is at the time that we find it, the greater statistically that there is a risk that the cancer could spread elsewhere in the body. The other feature is a biological sign. We now know some molecular information about ocular melanomas and how they behave. When there is a missing of a whole copy of chromosome 3 in the tumor tissue itself, this is one of the strongest risk factors associated with metastasis, and we call this monosomy 3. There are other markers of prognosis in addition to monosomy 3, and one of them is a gene expression profile test, which categorizes people into class 1, which overall is a good prognosis risk group, and a class 2, which is considered a bad or poor prognosis group. So these are probably the main risk factors associated with the possibility of the cancer spreading. I've included a diagram of what monosomy 3 looks like. This is a stain that we perform when we take samples of the tumor at the time of treatment. Normally, there should be 2 copies of every chromosome, but here you can see that there is only 1 in these ocular melanoma cells. So if a person has a good prognosis melanoma, meaning that they don't have the monosomy 3, they have 2 copies, which we call disomy 3, or they have a gene expression profile of class 1, we consider this a good biological molecular prognosis, resulting in a lower chance that the cancer should metastasize. When people have the missing chromosome 3, we call this monosomy 3. And usually these are associated with a class 2 gene expression profile. And this indicates a higher risk of developing metastasis. So we consider those people in a bad prognosis or poor prognosis risk group, where their risk of getting cancer spreading to the liver is higher. It's important to point out that although we have such advances in determining the nature and biology of the particular ocular melanoma, there are many other factors in the human body that come to play when determining whether or not metastasis occurs or not. I think it's important to point out that whether you have a low risk or a high risk, there are many things that you can do to help make your body have metastasis less or to increase your risk of preventing metastatic disease. What are some treatments for ocular melanoma, specifically focusing on the eye? In the past, before we had technical treatments such as radiation treatments, removal of the eye, called enucleation, was the standard of care, regardless of how large or small the ocular melanoma was. Today, we have advances that allow us to save the eye, and by saving the eye, we obviously have a better chance at saving some vision of the eye. The commonest treatments that we use today involve radiation. Probably the most common form of radiation for treatment of ocular melanoma is using the radiation in a brachytherapy plaque, pictured here. This is a photograph taken in surgery at UCLA, where a radioactive plaque is being placed on the sclera, the outside wall of the eye, overlying a melanoma. You can see that we sew that in place in the proper position to treat the tumor. Radiation can be delivered in many different ways, and different isotopes can be used, such as iodine, palladium, which is the commonest isotope that we use today at UCLA. Radiation can also be delivered externally. That means through a beam, and that can be delivered with proton beam radiotherapy or external beam radiotherapy. What are some other treatments? People always ask, is there anything else I can do besides radiation? Well, there's laser treatment that people have attempted in the past, and sometimes this can cause a temporary reduction in size of the melanoma, but our data show that this is not a definitive way to treat the cancer, and it often returns. People have also explored resection of the tumor, and that's essentially cutting it out of the eye. We do have some difficulties with this because tumors can still return even after a lot of it has been cut out. So it's really important to figure out the way to definitively treat these melanomas. Let's talk a little bit about the history behind treatment of ocular melanoma.
Oh, I'm not sure what happened, Tara. You got muted first.
You got muted, Dr. Tara McCannel. Can you hit your unmute button or Control Shift M?
Oh, she's on a Mac.
Oh, and I can't unmute you. Let's see.
Always a hiccup.
Okay, now can you hear me?
Yes,
Yes.
I hear you now.
All right, so let me go back to the presentation. I apologize, got somebody barking here, but we'll keep going.
No worries.
Okay. So the reason why there was this study called the Collaborative Ocular Melanoma Study, or the COM study is what we commonly have called it, is because people didn't agree on the best way to treat these eye cancers. Some people thought that if you tried to save the eye, you were going to definitely harm a person by contributing to metastasis, because you weren't just cutting that tumor out of the body. But another group of people felt that we should still try to kill the cancer and save eyes. And so in order to resolve this problem, this study was born. And the findings of the Collaborative Ocular Melanoma Study went far beyond just telling us, indicating the best types of treatment. Essentially, this study found that if you took the eye out or treated it with radiation, there was no significant difference in long-term mortality. And by long-term, this was about 15 years. So because of this study, saving the eye and saving some vision in the eye was recommended over removal of the eye when possible. This study also gave us a lot of information about how this tumor behaves, how people did in terms of outcomes. So it gave us much more information than basically to tell us that radiation therapy is a good option. So what do we do after the tumor gets treated? Well, it's important to continue the care of the eye because things can still change. We recommend evaluating patients carefully every 6 months after treatment. And what are we looking for? We're essentially looking to see that the tumor continues to respond and is dead. We're looking for possible complications of the side effects of radiation. And we're also looking for more garden variety problems that can happen with the eye, like macular degeneration, the development of cataract, people getting glaucoma. These things happen to people regardless of whether they have a melanoma or not. And it is critical to look for these things because they also happen in eyes where a tumor has been treated. So how do we know that the tumor has been successfully treated? Well, a successful treatment generally means that there's no further growth. Frequently, though, in addition to stasis, we often see reduction in tumor size. And that is because the dead tissue forms a scar and the body attempts to clear it away. So we see a lot of scar tissue in its place. A lot of people ask, when is my tumor going to be gone? And I reassure them that we see signs that your tumor is dead. And that's essentially the scar tissue that we can measure and see and confirm that there is nothing to be concerned about in the eye. Let's talk a little bit about some research that has been done in terms of types of treatment in the eye. Now we know that radiation treatment is beneficial because it can help save some vision in the eye. What about the types of radiation? As you can imagine, there are many different ways of treating radiation, and even between centers, different centers do slightly different things, whether it's in surgery, how they monitor people, how they may do a quick measurement of the tumor just before treatment to make sure that it still has the same dimensions that the treatment had been designed for. A number of years ago, we reviewed all published literature looking at types of local treatment recurrence in ocular melanoma. And we found that when we used ultrasound together with our radiation treatment, we had a much higher rate of treatment success. And so centers, because of this, at UCLA, many centers now adopt ultrasonography or use this in increasing the accuracy of the treatment. When we bring our ultrasonographer into the operating room, he can measure the size of the tumor. We can see exactly how the radiation plaque is sitting against the tumor. We can measure how much overlap and coverage that we're getting. And that allows us to make changes in the surgery, such as moving the plaque to a better, more accurate location to treat the tumor. The other thing that we can find is sometimes the plaque might sit in a slightly different way against the shape of the eye. These radiation plaques don't always fit snugly. Sometimes there can be some tissue between the plaque and the eye that increases the space. Ultrasound allows us to measure all these differences and recalculate so that our treatments are absolutely accurate. Let's talk about some of the side effects of radiation. The good news is that there are no side effects outside of the eye undergoing treatment. The radiation doesn't affect your brain, doesn't make you lose your hair, and it has no effect on your other eye. The only effects are in the eye itself that have the tumor. The most serious side effect is the side effect of losing vision, and that is because of damage to some of the non-tumor tissue in the eye, the macula, the optic nerve. The COMS research bank that found all sorts of things related to treatment after many years found that with conventional radiation plaque treatment, about half of people have vision worse than 2200 by about 3 years. They also are at risk of glaucoma. Some of these complications can be treated, such as glaucoma. If it is discovered that the eye is developing glaucoma, we can institute our usual excellent treatments for glaucoma and save the vision in the eye. So it's important to be monitored, to look for treatments, to look for complications that have treatments to them. And as I said, there is no hair loss. There's no radiation effect on distant sites. It is a very localized treatment. Here's an example of an eye that is suffering from a radiation side effect. You can see through the pupil that there is a cataract present. And in many eyes, developing a cataract after radiation occurs. However, cataract is treatable with standard cataract surgery. You can also see in this picture that there are a lot of abnormal blood vessels that have grown along the iris. You can see the little red squiggly lines. When this happens, that means that there's been enough damage and inflammation of the eye from the radiation treatment that the eye is reacting with creating vessels. And sometimes this can cause glaucoma and can cause blindness in people's eyes. Here's a photograph of the inside of an eye that has been already treated. You can see the remnants of the melanoma to the right, that elevated lump that is a little bit out of focus. And the white circle is the optic nerve of the eye. And this view is of the center of the vision, the macula. And you can see that there are all these white spots and red dots, little hemorrhages, and yellow dots. These are all signs of the side effects of radiation on the blood vessels. And this causes the vision to be decreased, particularly in the center vision. So the big challenges in ocular melanoma are losing sight and the risk of losing life. So what can we do about some of these things? In both areas, there's a lot of research going on. And at UCLA, one of the largest centers that treat ocular melanoma, we have contributed a lot of change to this field in the last decade and a half. The Stein Eye Institute is the largest ophthalmic oncology center on the West Coast. This is a rare disease, ocular melanoma, and most ophthalmologists and even retina specialists do not have much experience at all in making a diagnosis and treatment. We tend to see a lot of people referred because their eye doctors are thinking of the possibility of cancer but are just not sure. And we're happy to reassure people and to help guide people in the proper way of treatment and follow-up. And even an ophthalmologist, with all the training that we have, they may not see a person with a melanoma in their entire career. At UCLA, we work with the team of hematology oncologists, other ophthalmologists who help with other subspecialties that are affected with ocular melanoma, and we are a world-renowned ocular oncology service offering multidisciplinary approaches, including health psychology, including surgery, and even our colleagues in hematology oncology, where we have had clinical trials of new drug therapies for people who do develop metastasis from their ocular melanoma. So in our center, we include many different components, and some of these we touched on in the presentation. So we have done things such as vision-saving surgery, where we include radiation shielding intraocularly into the eye, and this is a new breakthrough that we discovered over 10 years ago and is now part of our standard of care treatment. In terms of scientific discovery, our ocular melanoma laboratory has developed over several years some valuable cell lines. That means getting cells from tumors in patients and growing them so that they can be studied for drug testing and pathway discoveries, which we collaborate with a number of centers, MD Anderson, Emory, and we also work with vision rehabilitation. We have a program where we educate and train medical students, residents, fellows, and international visitors seeking to increase their exposure in this unique area. We also have a strong collaboration with the psychology department at UCLA. In the past, we have had graduate students in health psychology doing research with us that have discovered some important needs to meet for patients who have ocular melanoma. And we currently have a graduate student who is defending her PhD and doing research with us where we are developing an intervention to help patients cope better and do better for their ocular melanoma. And at UCLA, we are leaders in tumor biopsy, where we have been able to take samples of the tumor and test for markers that we talked about earlier in the presentation. With more information, people can make better choices and also help direct people into clinical trials, which are ongoing. Let's talk a little bit about some of these to give you a bit more detail. At UCLA, we have data that show that new treatments can help save vision. Our research interests continue to be in prognosis with the Ocular Oncology Laboratory and with our collaborators. And most importantly, it is important to improve the patient experience. We want to reduce pain. We want to make things more comfortable. We want access to information so that people can do better after their treatments. And data and research have shown that the more information people have and understand about their condition, the better they will do, both psychologically as well as clinically. We also do collaborations with the Center for East-West Medicine, looking at holistic approaches to improve health. In terms of eye-saving surgery, we talked about the standard ways that radiation is delivered. Although we have excellent ways of treating tumors, the radiation side effects are a serious problem. At UCLA, we have discovered that silicone oil used inside the eye can attenuate the radiation and protect the optic nerve and macula. Our initial paper came out in 2010 in collaboration with our physics colleagues in radiation oncology. And later we showed with clinical data that there is, with ultrasonography, I'm going to switch gears to ultrasonography. We use ultrasound. We have, at a 2-year time point, we see 0 tumor recurrences. So these are all strategies to improve the accuracy of our treatment. And this is just a slide showing data at other centers. And of course, this is several years ago now, but other centers have a relatively high rate of recurrence, 10%, 5%, 14%. So where you get your tumor treated is going to have a different outcome depending on where you are. And this is our paper published back in 2012. And we mentioned fine needle biopsy. This is taking a sample of the tumor during the surgery to determine metastatic prognosis. And this we did first when I began at UCLA and has been the foundation for finding new discoveries of the cancer as well as giving patients information. And we have developed many ways of doing this safely in the eye. And we continue to train our fellows and other doctors who come through UCLA to offer the safest techniques for providing this information to patients. This is our initial paper many years ago now, but in the early 2000s where we showed this was feasible. And as you can imagine, we were met with much controversy. But today, fine needle biopsy is considered the standard of care to give information to patients. And we've had many papers and publications showing the safety, what we can discover when we take a biopsy, after many years of follow-up, how it's safe in experienced hands. And it is now a standard thing that if you treat melanoma, you must discuss this with patients so that they know about their cancer. We've also looked at the follow-up, how do people do when they are given this information about their cancer? So many faceted approach to our discoveries. Here's a journal which shows our techniques, many different methods of doing this, and many physicians and ophthalmologists have adopted these. Here's an example of one way that we can get a sample. This is a tool that we use in surgery where we can take a sample directly from the tumor, and it's difficult to see here, but there's little brown dots there, and we can use those in our molecular prognostic evaluation of patients. Here's our typical technique where we use a needle that we place into the tumor and take a sample. So moving on from needle biopsy, I mentioned that we have approaches that help prevent radiation loss. We don't have treatments once radiation is delivered to really undo the side effects. We do have injections of novel drugs that can be helpful, but they have limited success. The damage occurs at the time of radiation, and that is our only chance to do something different. So what we have discovered is that we can block radiation with silicone oil and essentially shield the sensitive structures in the eye. We showed that when we use silicone oil, which is a common substance already available to fix retinal detachment, we can block radiation by about 60%. And we looked at several years of follow-up where we showed less radiation, and in large tumors where we need lots of radiation, the visual differences are significant when we use silicone oil compared to standard of care. This is how it works. When we treat a melanoma, the brown tumor in the eye, we place a radioactive plaque on the outside of the eye. The rays of radiation kill the tumor, but they also affect healthy tissue inside the eye, which results in their damage. If we can fill the space of the eye with a substance that can block or attenuate the radiation, perhaps we can limit the radiation that goes to the healthy tissue of the eye. And this is essentially how our discovery of silicone oil can help improve vision after radiation therapy plaque. This is a graph from our paper demonstrating the results in large tumors, which is a group of people that we expect to see differences quickly. And you can see that there are higher proportions of good vision outcomes, the red bars being the plaque with the silicone oil. And when we look at poor vision and blindness, we see far less cases of that, to the graph in the right. Here is a case of someone with a very large melanoma. The melanoma is the bulge on the right. The bulge on the left is an associated retinal detachment. In this person, the vision was great at 20/40. And this eye would have been removed if we were following the COMS criteria and would be offered enucleation at many centers even today. However, this person underwent treatment with radiation plaque and silicone oil placement. And you can see the silicone oil there. Now that the tumor is dead and the retinal detachment has gone away, you can see the edge of the silicone oil bubble. And this is a person 1.5 years later with the oil removed, the melanoma has been treated, and the retina detachment is resolved, and their vision is maintained at 20/40. So another discovery we found was that if we switched our isotope, and our traditional isotope that UCLA had used for many years was iodine-125, which is what the COMS studies used, there are other isotopes that work similarly, and one of them is palladium-103. It was one of our physicists who pointed out that the electron coefficient for palladium was different, such that it should be more easily blocked by silicone oil than iodine. So we switched to palladium several years ago, and we have seen that there is even less radiation side effect with this effective form of radiation treatment when we use silicone oil to block it to protect the healthy tissues in the eye. So what sort of research are we doing in terms of metastasis? The Ophthalmic Oncology Laboratory did a lot of work in growing cell lines. And when we took cells from people with ocular melanoma, it was people who had the highest risk of getting metastasis, whose cells grew the best. So we had a number of cell lines that we were able to continue to grow and share with other centers doing basic science work and drug testing in the United States. Because when we are able to take biopsy specimens, which nobody had done prior to the early 2000s, we can actually learn more about the biology of the melanoma, and it can provide clues to genetic imbalances that lead to metastasis. So here is a picture of melanoma cells, I'm going to say ocular melanoma cells, that were grown from a patient's biopsy material. And you can see that they're forming pigmented clumps, just like they do in the eye. What about ocular melanoma treatments for the future? A person gets diagnosed with ocular melanoma, a biopsy gets performed during their radiation plaque surgery, and we can determine the molecular signature of a patient at the time the eye is treated. If we have appropriate drug therapies, then a person could take a drug for their specific molecular profile, which can help prevent metastasis from occurring. That is our vision. We have a lot of work to go before we get there. And what I've learned is that progress in science is usually not so simple. There are many other factors that affect whether a person develops metastasis or not. So going back to this diagram that I shared, which shows our whole person approach to treatment, the area that we are most excited about today is some of our discoveries that we're learning in health psychology. And this might seem surprising because traditionally, research in the laboratory and discovering unknown metabolic pathways was thought to be the way to cure cancer. To find the pathway, find the drug target, create a drug, give the drug, and kill the cancer. However, this path and this way has been pursued with somewhat success, but oftentimes the body is able to outsmart the drug and find another pathway to wreak havoc. So what else can we look at? So at UCLA, our group is very interested in looking at the effect of the mind and on one's psychology in staving off the development of metastasis. There's a lot of research in other cancers that show that excellent psychological health is correlated with lower risks of metastasis. And we have found in our psychology research over the past decade and more that there are a lot of issues that face patients and things that can be addressed if only we take the time to look. So I look forward to continuing to report our discoveries with you in all our areas of research, and particularly in the possibilities laid before us psychology. So I want to thank you all for your time and attention, and I would love to talk more about any questions you may have about our ocular melanoma program, new discoveries in the treatment of melanoma, anything at all. I'm here to answer your questions.
Thank you, Dr. McCannel. And I will keep you spotlighted. So I do see a question, and for anyone else, if you're using your computer, if you have a question, you can raise your hand, do the raise your hand function, and I'll call on you. We have a question from Jamie. Go ahead, Jamie. You'll have to unmute. Oh, I think they just left. No. Okay, while we're waiting for Jamie, Gerald H.
Well, you talked to me earlier, and what has been since the time we first met and you treated me? What is the progress towards restoring the eye that has gone blind? Is there anything new?
So that's a great question. What are the new things we have for giving vision back and for restoring sight where it was lost because of the radiation treatment and the need to kill the melanoma? So I don't think that we have anything that is going to regenerate the tissues that have succumbed to the side effects of radiation. And I know that a lot of us, people in my field, are really focused on some of these issues. And when I meet people for the first time who have this type of melanoma, and I know what may happen in the years to come, I really spend my effort focusing on the health of the better seeing eye and of the preventive things that we can do. Because even though a person may lose a significant part of their sight or even all of their sight in one eye, if we help with the other eye, because most people have a better seeing eye, people can still continue to do their activities. Unfortunately, we have some drug therapies that can temporarily improve vision when it is starting to fail from the side effects of radiation. But in the big picture, these don't really have much effect that is of benefit, but which I certainly recommend we do, particularly when people are noticing that at the outset of vision loss, there are definitely things we can do to kind of slow that down. But we can't ultimately bring back tissues that are damaged. There is a lot of work in restoring sight in terms of computer chips and connecting to neural chips that are implanted into the eye. But the people who benefit from those are really people who have no sight, who have black vision in both of their eyes. And for those people, these discoveries are really helpful. I think in most of our population of people who have had ocular melanoma, they wouldn't be candidates even for those types of treatments because their vision with both eyes together is too good to qualify for some of those strategies.
I have another comment. I have read that there was in a book, actually 2 books, that there is a connection between the tongue and the eyes somehow, and that there was an experimental situation that you could put this in your tongue and begin to see it with your eye, or see with it as if you had your eyes. Any comment on that?
Well, I'm not familiar with that work. I know that even there's receptors that are being discovered outside our external ear that give us the ability to sense that a person is next to us, even though they're not saying anything. And some of these are correlated with some visual photoreceptors. So it's not just light that can stimulate visual phenomenon. It's actually many other things that is much more complex than we ever knew. So I'm not surprised that there are connections that we've never heard of before, but that people are learning about. It just really makes me appreciate how little we really know about things, and that there's so much to learn, and that we really need to be open about all these different possibilities. I mean, it would be amazing if we could do something with the tongue and have some connection where people can sense visual phenomena. I mean, that's fascinating.
Well, it was a fascinating read in the books. It's just the guy has 2 books. I don't have any reference anymore, but there were 2 books, and you went through it, and you found out that some person began to get sight, and after using it for a while, they were able to see quite a bit. That's enough for that now.
Yeah, no, I think that's fascinating. And I think it really, like yourself, I mean, you need to be open to all these other possible ways that we can improve and that we achieve health. And one of the things that, I mentioned that we do have a collaboration with the Center for East-West Medicine at UCLA. And over the last few years, I've learned a lot about acupuncture, and that in Chinese medicine, there is an eye-liver connection. And when I heard that, I thought, wait a minute, ocular melanoma spreads to the liver and we have no idea why. So I think in order for us to make real progress in science, we need to be totally open-minded and be willing to come to terms with the fact that we actually know very little. And we need to just explore all these avenues, because probably if we stumble upon an amazing discovery, it's not going to be through the traditional channels. So I'm over my recent mid-career and later in my career. It's really struck me, and I have to say that, you know, I've seen this in patients. We talk about the prognostic risks and the biopsy results, but you know, there are people who had huge tumors, who had the worst prognostic markers, and it's been 20 years later and they're doing great. And I can see from the person that there's other things going on that contribute to their excellent health. So we still have so much to learn. So I appreciate you bringing that really interesting article, or the book that you read about that. I'm really fascinated, and I think we need to look into that.
The Braille Institute has those books, but I can't tell you what the names are. Thank you.
You're very welcome.
Yeah, that's very interesting. Okay, any more questions? And I'll add a comment to that too. If you're experiencing vision loss from radiation or cancer or otherwise, at the Braille Institute, we do offer low vision consultations and rehabilitation, and focusing on compensatory methods for your environment, for your activities.
Can you tell us a little bit about what, you know, how the process for people to come and meet somebody there? I know of, and we do have people who do go to the Braille Institute, but a refresher for me would be great too, and I can help spread the word.
Yeah, thank you. Yes, thank you for referring. So the process starts with a doctor referral form filled out and then sent to our center. So we have centers in Santa Barbara and LA. And then from there, a initial consultation or evaluation is scheduled with a low vision specialist or a low vision occupational therapist.
Okay. Thank you.
Yeah. And so, go ahead. I'm so glad, Gerald.
The Braille Institute has been very helpful. Matter of fact, in San Diego, where I am, I'm now taking Braille. I've been doing it for several years. It's really tough. I don't want to go into that, but and they don't necessarily charge. There's not a charge to that. It's all donation based, so they're very helpful. Don't anybody that is thinking about it, go see them.
Thank you, Gerald, our spokesperson. And on that note, I will pull up a contact information slide right now to just keep on the screen for everyone. Let's see here. Okay.
Can you make it a little? There we go.
There we go. So I have Dr. Tara McConnell's information. And then if you'd like to contact the Braille Institute for any questions or a low vision consultation, you can call 1-800-BRAILLE, or you could also visit brailleinstitute.org. And I also listed the Santa Barbara Center phone number here.
I have a quick question about resources that you might have. You know, one of the things that people worry about, you know, especially in the beginning, is sort of, how am I going to be able to do the things I normally do? And I really feel that it's important to highlight that, you know, even if you've lost some vision in your eye, when you use your eyes together, most people can do really everything that they've done before. I mean, almost always I see that. And do you have materials that can kind of review, you know, binocular vision, how to continue to, you know, is there anything that you might have that we could, I'm just thinking if there's any materials that we could have in our office to give to people, just so they have that. They might not look at it right away, but is there anything you could send us?
I think that's an excellent idea. Yeah, just to have that resource available, and we can definitely send you some resources for you to have in the office. That's a great idea.
Thank you.
Yeah, thank you. And are there any other questions? Tracy, I have my screen up. If there's any other questions, will you let me know?
I think we're good.
All right. Well, thank you so much. And thank you everyone for joining us.
Thank you for answering.
Oh, wait. Oh, I see one more question from Mercedes Romo.
Hi, good morning. Thank you. A very quick question. Just do CEU credits apply for this seminar?
I don't believe we started with a code. Tracy, am I correct?
Yeah, you can go ahead and give a code and we'll get those sent out.
Okay.
I would like, you said this is recorded. I'd like to get a copy of the recording if possible.
Yes, we can have that done as well. We'll send the recording out. I think it gets developed by marketing and then we can share.
Okay, please. You have my address, so I'm sure you can just automatically send it to me.
Okay.
And the code will be workshops 2022.
Thank you, Tracy.
Is it?
Okay.
Nice to see you, Gerald.
Yes, I doubt that I'll be seeing you again, but I was really enthusiastic to come to your seminar this time.
No, thank you. And good luck learning Braille. That's great. It's like you're learning a new language.
Oh, it's really hard. You think the alphabet's hard? Try Braille.
It's great to hear.
All right. Thank you, everyone.
I do.
Have a
Bye-bye.
good day.